Hello, I am Dr. Carrie Bedient from the Fertility Center of Las Vegas, and we are back with another episode of Fertility Docs Uncensored. Do, 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 do. And I am joined by
We
my
need theme
two.
music.
What was
Oh,
that?
well, I think we have like intro music, but I'm thinking more along the lines of
Dun dun
superhero.
dun.
Do,
Hey,
do,
Abby,
do.
maybe you can hook us up with somebody in Nashville.
Hey, there you go. Yeah, I'll see if I can work on that.
We need
I
a
think
song.
I think we need to go big. Does anybody know John Williams?
No, but he's probably in Los Angeles. You're closer to John Williams, probably.
Probably.
Yeah, that'd be
Except,
good. He's
hmm,
written like Star Wars music and like all kinds of.
Star Wars, he did Harry Potter, he did E.T., he did like
Indiana
all
Jones.
Schindler's List, all of the big, beautiful scores, Jurassic Park. Okay, so to our listeners, the mission for the week is if you know John Williams, will he write us a
A theme
minute to
song.
2 minute theme song on maybe the superhero theme, maybe the epic theme, an epic theme.
An
I will go
epic
with
theme.
epic.
Epic.
Yeah.
Epic theme.
Anyway, I am joined by my two magnificent co-hosts, Dr. Abby Eblen from Nashville Fertility Center
Hey, everybody.
and Dr. Susan Hudson from Texas Fertility Center.
Hello, everyone.
How you guys doing?
We're good. We're good. We're recording a little later than we usually are, so we may be a little goofier than normal.
Yeah, we're kind of goofy, I think. We're all tired.
A little bit punchy. Well, and especially in between all of our recording, we've been talking about all of the projects that we have going, which for the longest time it was just like, okay, what do we need to do to keep the podcast running? And
Well, we still have that conversation too, but
well, we do have that conversation. Like that's a weekly conversation,
yeah.
but more recently we have been diving into bigger, sexier, hotter,
We're so excited. We got big things
flashier
coming.
projects. So, okay, so Susan, talk about your baby.
So my baby is, we are going to have a Fertility Docs Uncensored conference in New Braunfels, Texas, which is my hometown. So it's right in between San Antonio and Austin. So we have two fantastic airports if you need to fly in. It's going to be October 28th, 2023. It's going to
Saturday.
This year.
this year. It's going to be an all-day conference. We're going to speak. We're going to have some amazing speakers come in. We're going to have some sponsors who have information about different fertility, thingamabobs, all kinds of good stuff. We're going to have some yummy foods, some exciting conversations. It's going to be very, very interactive. You are not going to be sitting there and falling asleep. I promise you, because, we're definitely not going to let that happen. And I'm just so excited to have so much information in a full day for people who are, searching out that information.
And we get to meet all of you. So this is going to be fun.
Mm-hmm. And you guys get to meet each other because one of the biggest things is isolation in fertility couples, where you feel like you are the only one. And from three people who have full-time practices, you are not the only one, honey.
You are not the only one.
And so we're hoping that this can help kind of organically bring up some connection between people so that folks get extra support. And we'll do a cocktail hour at the end of the day so that for a smaller group of people who want to hang with us, we can have a little bit of extra time, and it's going to be fabulous. So keep your ears out as we're setting everything up. We will get more information out and about, but tell your friends, bring your bestie, bring
Significant
your partner.
others. Yeah. Bring your partner, significant others, friends that are going through it too.
Come play with us. So
that's right.
Eating is limited. So, tuck it in the back of your brain so that we can do this. Okay. So that's project number one, is the conference, October 28th of 2023. Project number two, Miss Abby, drum roll, please.
Boom. So we figured that there's so many people that have so many questions about IVF. And, even for us as physicians in the office, when we try and talk to you guys about all the details of IVF, we just skid over just the big topics. And, we feel like we fill in some of the details when you come for different office visits. But long story short, we feel like there needs to be a book written by physicians that do IVF, and also physicians that have been through IVF, which we all meet some of those criteria. And so we're going to write a book about IVF. In fact, about a fourth of it is already written. We have a literary agent, and hopefully we'll get a publisher soon, and we're going to get our book written, hopefully.
We're actually way more than a fourth. We're at, with all the emails that you sent this weekend, we're at the very least at a third, plus with what Susan
Okay,
had
maybe a
done,
third. Maybe a third.
we're hovering between a third and a half, which
Yeah.
like
Okay.
I am frankly very impressed because all of us have day jobs. And
Yeah.
so we're doing all of this in
And
spare
family
hours.
members and yeah.
Yeah. So
But it's so excited, and it just shows how much we love all of you guys, because
Yeah.
I mean we're wanting to fill that void, and we want to get people the information they need, and good solid information, not just hearsay. And so
No more
um,
Dr. Google is what we're
yes,
hoping for.
yes.
yes. Yes. I feel like we need to make merchandise of some sort, including a mug that says, don't confuse my medical degree with Dr. Google.
Yep.
But that's a future project. We are not there yet, and we are not going to start that one because these two other projects are big and unholy right now. So
Carrie's looking directly at me when she says we're not going to start anything else.
damn straight. I know who the culprit is. Although, frankly, on this one, Susan has gone balls to the wall on the conference. Abby has gone balls to the wall in the book. And I am just like holding everything together in the middle, making
You're the
sure
connector. You're keeping everything moving forward.
Yeah, okay. Let's pretend I'm useful.
You
but
are very useful.
You're very useful,
You
Carrie.
are very useful.
You're our financial wizard, or you deal with all the nitty-gritty details regarding all that stuff.
Contracts.
Keep us
yeah, well,
Those
anyway,
are just as important.
no more big ideas until we get at least one of these fully kicked off. But okay, so those are the big ideas. Keep your earballs open for those. And
Earballs?
earballs. Yeah.
Okay.
Eyeballs and ears, earballs.
Okay.
Earballs.
And Susan, do we have questions for today?
We do. All right. So, hello, I am 32, and my husband and I are doing IVF for tubal factor. Standard infertility workup shows no other concerns. History of one ectopic pregnancy. Decided with our doctor to do conventional fertilization, forego ICSI only, because we asked about risks and the data that exists correlating ICSI to childhood cancers. We were not against ICSI, just curious and wanted to minimize any potential risk for baby child. We discussed lower fertilization rate with conventional IVF and new risks if it's not working, but doc was optimistic and we went for it. After retrieval, we had 28 eggs, 19 mature, 0 fertilized.
Ooh,
Discrepancy,
yikes.
or do you guys never do conventional IVF for this reason? Do we likely have other infertility issues?
Yes.
Wow.
Yes, you
I think
likely have other
I think you
infertility.
nailed the fertility issue, unfortunately, right there. And that's exactly why we get nervous. It only takes one situation like you guys had for all of us to it gives us sort of post-traumatic stress disorder if somebody doesn't do ICSI, because we know with ICSI, we can have pretty good fertilization. And unfortunately, as you found out, it really is the pits. You have a bunch of eggs, but there's generally no going back. Once you go past that window, the sperm and the egg have to get together at a certain amount in a certain amount of time. And if you don't get the sperm and the egg together, you can try doing ICSI on the second day, but generally it doesn't really have very good success. We've had limited people that have gotten pregnant that way. So yeah, we in our practice, I don't know that we do conventional on anybody.
Do you do any conventional, Carrie?
Very, very rarely. ICSI is our default. Like when I was in training, we would do conventional. We would only do ICSI for very specific male factor. It was totally by the book. And that has been several years ago now. And I still remember making those phone calls of, I'm really sorry, ma'am.
Oh, I do
nothing
too.
fertilized." Like,
That is not a fun phone call to make
yeah,
at
those are
all.
awful phone calls.
Yeah.
And like Abby said, rescue ICSI, just
Rescue.
and all that.
Rescue. It's risky.
Risky? Risky?
It
It's risky. That's what it is.
is risky. It is risky.
Rescue ICSI does not tend to work very well. And those are just awful phone calls. So we tend to use primarily ICSI unless somebody very specifically requests not to do it. Now, I have not heard a whole hell of a lot about cancer risks with ICSI. One of the concerns is that there's an increased risk of GU, so genitourinary, think kidney, bladder, that equipment, disorders after doing ICSI. But there's starting to be more and more studies that more accurately compare control groups. So whenever we're thinking about studies, it's not just the group where they're doing something, it's who are you comparing it to? And traditionally, a lot of the IVF studies have been compared to people who get
normal,
pregnant.
fertile people.
People who
Right.
get pregnant spontaneously, that is not the same group of people. There
Mm-mm.
was a very nice study that came out of one of the Scandinavian countries, which have these amazing registries, so they can track everything really well. And it compared people who got pregnant with IVF, with frozen embryo transfers versus people who got pregnant without. And granted, it's not quite the same as ICSI. You know, ICSI by itself has a higher likelihood of GU disorders, primarily because the people originally doing ICSI were people who had male factor.
Mm-hmm.
And that's got a correlation. But when you really control out the groups and look at infertile people who managed to spontaneously get pregnant versus infertile people who got pregnant through IVF treatment, the problems are the same. They're very, very
Mm-hmm.
similar, because it's the underlying cause of the difficulty getting pregnant, not the treatment.
Procedure itself. Yeah.
Yeah. So,
Interesting.
Very cool.
all right. Want to
Do
do
you-
one more question, or we
We
want
can
to
do
move on
one
to our
more. Would
topic?
love to.
Okay, let's do it.
All right. Thank you all so much for the podcast. It's been so insightful, and I've binged nearly all the episodes. Thank you.
Oh, that's
I
sweet.
really enjoy listening to y'all. My question, we can only afford one IVF cycle. Consulting with clinics abroad, one offers express PGTA for day 5 blasts plus transfer the following day based on results. Standard PGTA also offered can include day 5 and day 6 blasts with standard batch test, return later for FET. Considering travel money, paying more for express test to possibly eliminate second trip for FET is tempting, plus not stress for 2 to 3 weeks while waiting, but want best chance of success, especially given advanced age, low odds. Fresh versus frozen, testing either way, better for success. Me, age 43, Hubs 39, AMH 1.86, FSH 8.9, AFC 15, semen is good.
Holy crap, girl, your labs are good. I mean, for 43, like
They are great for 43.
they are
Yeah.
great for 43. Okay. Can I answer? Can I answer?
Yes, it's
You can
your
answer,
question,
you can answer.
Carrie. You go. You go.
Carrie, as our international expert.
So there's a couple things that play here. Number one is the fresh versus frozen question. And when you are doing a stim over the age of 40, you are more likely to have hormonal abnormalities that make frozen embryo transfers a really beneficial thing to do, because your progesterone is more likely to rise early. And so that is going to compromise your success with the frozen embryo transfer. And so that's not to say it's a guaranteed it's not going to work.
With
It's
the
just
fresh embryo transfer, you said?
if you have an elevated progesterone level, that is going to compromise your success with a fresh transfer.
Mm-hmm.
And
It's
so,
very, very likely when you're in your 40s.
which is very, very
Yes.
likely. It's not guaranteed. You know, there's exceptions to everything, and may you be the exception in every way. But that is a big issue. The next thing is this express PGT, which really makes me worried based on how some of the better platforms for PGT are run. You just can't do them that quickly. Like the
Mm-mm.
science itself does not permit it. And so that makes me wonder, are they going with a lesser platform in order to do it? In which case, does it make more sense to just transfer, if you're dead set on a fresh, transfer the best embryo, don't biopsy, don't screw with it. That means you get the advantage of not messing with it, but the disadvantage of not knowing the genetic testing, which, I mean, that is something to spend a lot of time thinking about. But you may get a better result just doing fresh straight in and then doing more conventional standard PGTA that is not this express turnaround quickly. The last thing is with international clinics, depending on where you are doing it, the standards and the general accepted treatment is very different. So for example, in many countries where IVF is completely paid for by state healthcare systems, their standards of care are really different. And when you look at the studies that come out of those countries, the success rates that you see are very different. And part of the reason they're very different is because when someone is looking at how do we do this as inexpensively as possible, because it is a government organized and funded program, you end up with very different medicine than when people are having to pay for it. And the goal is we're going to do this once and we're going to be successful and we're going to be done. And so the underlying motivations behind those two things are very different. There are pros and cons to both, because wouldn't it be amazing to have everything paid for? But when you look at the studies coming out of those countries, they have very different success rates. And so be really
specifically, you're saying very low success rates or lower success rates.
Yes. And that we have a lot of discussions about that, because a lot of our patients are coming, I've had a patient who did, I don't know, 6 cycles in France with no baby, and first one with us, boom, she had a baby. And I had another guy that I just met on the trip that we took to Brussels, where he and his partner, both males using an egg donor, they did multiple cycles and multiple transfers in Canada, and they got down here, boom, first cycle. And so the drivers behind how we do medicine here are different. And just know what you're getting into, because I've had enough people come back to me after doing this internationally, where they spent less money, but still a lot of money, and they still had to come back to us. So just be really careful. Really, really careful, please.
Yeah, I'm not aware of any place that could check 23 pairs of chromosomes and get back the results within 5 days. We used to several years ago, a long time ago. At one point, we did 5 chromosomes. We looked at those. Then I think we were able to look at 9 chromosomes and get the results back and still do a day 5 transfer. But we've never been able, our center's never been able to get 23 pairs of chromosomes back and do an embryo transfer on day 5.
So it is possible, because that's exactly how I did mine.
Oh, you did? Okay.
I did a fresh embryo transfer, did PGT.
Oh, okay.
Granted, this was back in 2009.
Okay.
I think 2010. Yeah, 2000. I did this back in 2010. So, but it was at a place that actually could do it in-house. It was one of the ginormous institutions and that type of thing. So, I mean, it is possible, but make sure you're actually getting what you think you're getting.
Yeah, ask how many chromosomes are going to test.
Find out how many chromosomes are going to test. Find out what type of platform it is.
It's probably microarray, don't you think, rather than SNP based?
I would definitely say,
probably,
which is, you realize you're going to sacrifice some degree of accuracy.
Yeah.
Okay. And I see quite a few people. Carrie sees people a lot from Europe and stuff. I'm sure she gets quite a few from Mexico as well. We have lots of patients from Mexico who come up who have not had success. I have lots of people in Texas who go down to Mexico trying to get an expensive IVF. And, granted, I am sure some of them are getting pregnant. Okay. But we see a lot of people, just as Carrie said, the standards just aren't the same. We are practicing similar medicine, but it is not the same medicine. And so just make sure if you really, if you are making the difference of, it's going to cost maybe $12,000 versus $20,000, I think you should spend it well and wisely, and make sure whatever you do, whether your outcome is positive or negative, that you can, at the end of the day, say, we did everything we could within whatever those limits are. And that's going to vary from person to person, from couple to couple. But just do what is going to make you feel like you have no regrets. And for some people that may be doing the international option. But just really make sure you know what service you are paying for. That's a good question.
That was a really good question. Okay, so topic of the day is going through the IVF medications for people, so they know kind of what they're doing, how they're doing it, the reasoning behind everything. That's an important one, because oftentimes if you know why you're taking it, if something doesn't make sense, you can figure it out, because all of us have had the experience where the pharmacy sent the wrong drug and somebody picked it up and they didn't cross-check and they didn't think about it, or they got an instruction that wasn't quite clear, they interpreted it differently, whatever it may be. So the more you know, the higher the likelihood that if something is not absolutely perfect, which, given that everybody's human, happens, you can catch those things. So
I want to
let's
say something first.
say all the
So
things.
when you get your giant box of medicine,
Yes.
okay,
100% what
first of
Sue's
all,
gonna
know
say.
it's going to be a giant box or bag of medicine. Like, don't freak out. Okay, there's a lot of stuff in there. But the most important thing is don't randomly take something that your clinic has not told you to take yet. Everything
Yes.
has a time and place. Okay. We get it sent to you so you have everything with a big bow. Okay. But don't take it. If you are in doubt, I am absolutely sure you can call your office. Even if it's after hours, there's going to be an on-call service. There's someone you can ask before you take something randomly out of your box.
Also, the secondary part of that, when you get your big box of goodies, dump the whole thing out carefully and don't throw away any of the packaging until you know that you have everything you are supposed to have.
Yes.
Because there is nothing that feels suckier than going, well, crap, where's this $500 bottle of whatever? And realizing,
I
oh,
threw
it
it
was
away.
sent. And you threw it away because all the pharmacy, well, I don't know about all, many of the pharmacies have like video packaging. So they know exactly what they sent you and they know that it went in there and it turns out it got, caught in some of the packaging and thrown away. So take the list and cross check it to make sure you have what you think you have, because there's different brand names, which we'll talk about. And you just want to cross check all of it to make sure you know what's the saline, what's the legit medication, what am I doing for when, and do I have everything in my possession that I think I need to?
And while we're on the subject, on the weekends, if it's Friday afternoon and you're going to start something over the weekend, or you're going to increase your dose of something over the weekend, make sure that you have what you need for the weekend, because most of the time it's really difficult. The worst phone call I say that I get on the weekend is a call at like 10 p.m. on Saturday night going, I'm supposed to take my trigger shot tonight, but I don't have it. There's not a lot we can do about it
You
at
can't
that
go down to
hour.
your local Walgreens or CVS and pick it up. Okay.
So just make
And
sure on the
especially
weekends.
holidays. Like, you can't get meds on holidays. So like, be prepared.
Yeah.
And I know we all have signs up in our office about, make sure you have your medications and things like that. But seriously, you have to make sure you have all your stuff. Ask if you are going into a weekend or a holiday, be like, how much medicine do I need to make sure I have? And we know our goal is for you not to have extra liquid gold sitting in your fridge when this is all over. Okay. But sometimes we have to do
But the opposite is worse.
policy. Right. A little insurance policy, because there's some meds we just, you can't do what we need to do without it. So.
And as you're ordering meds and you're looking ahead, keep in the back of your mind, not only the holiday weekends, not only the regular weekends, not only the random holidays, think 4th of July, which this year is on a Tuesday. So that's going to screw something up for somebody somewhere along the way. Also remember to keep the random ass weather things in mind.
Yeah. So, storms up east, those hit you in the summertime all the time. Storms up east,
the electrical
hurricanes and blizzards.
Blizzards, ice storms. Ice storms are the worst. So keep all of the weather stuff in mind. So even if where you live is totally fine, if your medication is coming from somewhere else, Texas, Florida, and back east tend to have the worst records for some screwball weather event coming up that jacks up somebody's meds. And your clinics will oftentimes have maybe an extra dose or two, and patients get mad. Well, why don't you have everything? We are not pharmacies.
We're not supposed to, we don't dispense medicines.
Yeah, like we may have a sample here and there, but we are not pharmacies. And so if you remember nothing else from this episode today, count your meds, check to make sure you have, and if you're going into a weekend or holiday or travel or screwball situation, make sure you have what you need to have well in advance.
Yes.
I feel like that's the main PSA. Like, screw the
rest. So if you don't remember anything, that's the one thing to remember from this episode, right?
But you can't keep on listning to learn about what we were planning on talking about anyway. But we kind of got diverted telling you all the things that are actually really
preaching
important.
A little bit, weren't we? Don't forget your medicines.
There were soapboxes in all three states right there.
That's right. Yes.
Okay,
Sorry,
let's
we've all been caught with those kind of phone calls at midnight or whatever.
yeah, they're it's the worst feeling. So
Yes.
let's talk about pre-treatment medications. What do y'all potentially use? And these are oftentimes not mandatory. This is very much situation dependent, but what kind of pre-treatment do you consider using?
So a lot of times we'll start out with birth control pills, for example, which seems really counterintuitive to a lot of people. If I'm trying to get pregnant, why are you starting me on birth control pills? Couple reasons. One is, we like when you start out, when you've got everything planned, you've got your schedule planned, you've got your work, you let them know when you're going to be off and when you need to go in. If you come in and all of a sudden you have this big cyst on your ovary, and you can't get started, it kind of throws everything off for another month or two. And so it helps with timing for you and timing for us as well. And also too, you know, it, I guess the other reason not to do it would be if you had like some sort of clotting disorder or something like that. But generally, it's good for timing, and it also decreases the risk of having cysts on your ovaries, so you can kind of get started when you want to. But it's something that's negotiable. So if you don't like birth control pills, they don't do well with you, then we can always work around that if we need to.
So it
Mhm.
also helps your ovaries get organized. So your ovaries chose 2 months ago which little follicles we were going to see this month. However, we like those follicles to be all about the same size because in IVF, the big follicles call the shots. So if you have 2 or 3 follicles starting off your stem that are still small, but let's say they're 9-10 millimeters, and then you have 15 of them that are 2 or 3 millimeters, it's like they're all technically small, but you're probably not going to get the nice tight cohort of all your follicles growing at the same rate. And you don't want those big ones to be like, hey, you gotta start triggering me now. And then those little ones are like, I'm still 12, because then we're not going to get as many mature eggs. So it does help us not only on timing, but it actually is logistically a benefit in certain people. I tend to use birth control pills in people with good ovarian reserve.
Mhm.
And in people who have poor ovarian reserve, I usually do what we call an estrogen priming.
Yep.
Um, and the estrogen priming, there's lots and lots of variation on this. This is definitely
Mhm.
one of those art to medicine types of
Everybody's does
things.
it a little differently. Yeah.
Everybody does things a little bit differently. So we'll kind of describe what we do if we all do this type of thing. I typically use estrogen tablets after about a week post ovulation. I start some
Mhm.
estrogen. Actually, I usually use estrogen patches to make things a little bit easier. And then I also use a medicine called Cetrotide, and we'll talk about Cetrotide in a little bit. But I use the 2 of them to essentially let your ovaries take a nap for about a week. Okay. So that when you start your stimulation, with your period, and when you get you started with your stimulation, your ovaries are like, woohoo, we're ready to party. So that's kind of what I do in people with diminished ovarian reserve. How do y'all do estrogen priming?
I
I
do.
do.
I don't routinely do it. Do you do it? I usually do it in somebody that's had a dominant follicle. A lot of times I'll start back and do estrogen priming with them before that. Do you do it all the time, Carrie? Do it more frequently?
I do. I really like the estrogen cetrotide protocol that Susan's describing. That's one of my favorites. And I tend to do it whenever I have someone who has a higher likelihood of having a dominant follicle being selected before we have given them permission to. So typically, if someone's day 3 FSH and estradiol have been misbehaving at their diagnostic testing, that's who I'll do it. I also tend to do it a little bit more on my patients who are 40 and older, just because they're
Mhm.
the ones who,
Have
if
dominant follicles.
they're the ones who have dominant follicles. And so even if their testing is perfect, I'm a little bit more likely to. Um,
Essentially,
and
mine is 38 and up, and then anybody
yeah,
with abnormal ovarian reserve testing.
yeah,
Yeah, what that does mean though, sometimes patients have not liked it because they're like, but I want to get going this month. Well, you have to
yeah,
start in the luteal, the second part of the cycle and the previous cycle. So, and
yeah.
kind of back to what Susan said, it's kind of like I always say it's like baking cookies. Like you don't want some cookies to bake really quickly and some to bake really slowly because none of them are kind of any good. So, kind of estrogen priming kind of starts the cookies back at baseline so they all kind of bake at the same rate essentially.
I really like that cookie example. I'm going to steal it.
Okay. I've still on a lot of
It,
both of the
it's one
things
of
that you
Carrie's
guys
two
say.
favorite things: analogies and food
Yeah.
making,
Well, especially cookies, sweets.
especially
I mean, come
cookies.
on.
That usually gets a smile on my patient's face when we're talking about a serious topic. It usually makes people smile a little bit. So
Yeah.
I
that's a
like
good
that
thing.
one.
So I have a question for you guys. Do you ever use growth hormone as a pre-treatment, or do
I
you
don't
only start it earlier, or
I
start it early in actual treatment?
I started in
So
actual treatment.
I've started it earlier and I'm not seeing great success with it. Plus, it's really expensive. So I hate to start it too far in advance. But I had a patient who had used it and gotten some deals on it. So she started it like a month in advance, but we didn't really see much benefit, at least in her particular situation, to
That's
starting it
pricey.
early. It's
Yeah.
very pricey. Yeah.
So one of the studies that I found said you could see max benefit if you had it like 4 to 6 weeks prior to
Yeah.
actual retrieval.
You'd
And
be
so,
spending thousands of dollars if you
That
got
is
that.
lots of thousands of dollars.
it was
That's like
lots of
you've
Yeah.
already
thousands.
paid for another IVF cycle,
Right.
thousands of
Yeah. I don't.
dollars.
So I use growth hormone maybe twice a year, and they're always in the situations where I have thrown absolutely everything else at it.
Yes.
And so
Yes.
I don't use it very often, and I don't see amazing results most of the time. Every so often we'll get something good. So it's not in my favorite set of protocols, but sometimes I will start that before the stim
Mhm.
cycle when we've had a lot of counseling ahead of time, because we always talk very frankly about, look, this is a really expensive med and the data
Yeah.
does not necessarily back it up. But for people who want to know that they have tried absolutely everything, that's typically where that comes in. Okay.
Yeah. And by the way, the other name for that is omnitroph. So if you're looking at your
Yes.
med list, it's omnitroph.
So once someone comes in and they have their baseline ultrasound and labs, and they see that everything is beautiful and squeaky clean, and the hormones are behaving, and the ovaries have appropriately taken their chill pills, and they are starting out calm, what is the first set of meds that people typically go on?
So
Yes.
typically they're going to start on in the United States, it's going to be a form of FSH, usually called Follistim or Gonal F. They are very, very, very similar. People have different preferences for different things, but in my general opinion, they are probably just as efficacious as each other.
Mhm.
Um,
Yes.
and then your those medications are pretty neat because they generally come in pens. You can get them in little vials where you have to mix them. But nowadays I would say most people use those medications that are in pens, and you literally just dial up to whatever amount you need. So another one of my little helpful tips is when you're using one of these pens, all of these pens are going to have overfill. Okay. So there's a little
Yes.
bit of extra medicine.
Mm-hmm.
So say you're taking, we're going to just say you're taking 200 units a day. Okay. So you dial up to 200, do your injection. And then the next day you'd change out your needle, dial up to 200, and say it was a 300 pen. Well, you could do your injection, and wherever it stops, whatever number is left there is how much you still need to do. So you could
Hmm.
dial up your new pen and do that additional amount. And, a lot of times you can get an extra 75, maybe even 150 units of medicine out of a pen. And that's quite a bit of money savings.
Yeah, it
Mm-hmm.
sure is.
I can say that we actually calculate, we include the overfill when we calculate how much medicine for you to order. So that's part of the calculation system.
All right. So there's FSH, which is Follistim, Gonal F, whatever brand name happens to come out. What else do you oftentimes give starting either from the beginning or early on in a stim cycle?
So we'll do either HCG, so just the typical HCG bottle. We just pull out just a little bit every other day. The other medicine that we give sometimes to sort of accomplish the same thing is a medicine called Menopur. It's an older medicine. It's been around for longer. And it's one of those ones where it has lyophilized powder. So you have to put fluid in there, which is the way I did IVF. You have to basically reconstitute the powder. You have to mix it all up and then draw it up and give it. The reason we give those medicines, and we sort of think of FSH, of HCG as being sort of a milder version, but with each one of those, you sort of have the same impact as if you get a little bit of the hormone LH. So we think luteinizing hormone is not an absolute, but we think in some patients, it may help a little bit with the maturity of the eggs. It may help a little bit with the eggs coming out of the follicles. For most patients, HCG every other day is cheaper and easier to do. But for some patients, in certain situations, and this is where the art of medicine comes in, some patients actually get Menopur as well. So they would get FSH, a dose of FSH, they'd get a dose of Menopur. The Menopur is dosed the same way as a FSH. So usually we tend to increase in increments of 75 international units or 75 IUs. And so if you're getting Menopur, like if you did 150 of Clomid, and 150 of FSH in the last cycle, and now your doctor's going to add Menopur, it's really the equivalent of going up by 30% on your dose as well. So you get a bump in your kind of FSH LH dose in addition to the FSH that you took before.
And then there's some different ways of doing it. I typically do about a 50-50 protocol ish. Depending on what the total number of units that I think you need to have. Some people do less. There's some data to say that the kind of 50-50 may give some better outcomes in certain individuals and that type of thing. What do you do, Carrie?
For the most part, I'll add in a vial of Menopur and then make up the rest with FSH. Doing Lupron flare is a little bit different. Depending on specific history, I'll change it up. But I like to have at least a little bit on board through the majority of the cycle. How do you guys?
One more thing to add. There is one group of patient, and if you're in this group, make sure that you get this. There's one group of patient that you really need both FSH and LH.
Yeah.
And so the patients that have a condition called hypothalamic amenorrhea that we've talked about before, it's kind of what runners get, and people that are anorexic, and then some people that have stress, and sometimes just mild combinations of all three. They tend to be really thin patients, and it's pretty impressive. They just do not respond at all. As a physician, if you just give them FSH and you were like, oh, I forgot that she has this condition, they just don't respond. So those are patients that absolutely need both FSH and LH typically.
So another group that is at increased risk of that are people who are also born with what we call midline defects. So if they have if you were born with a cleft lip or cleft palate or something like that, you may be at a higher risk of having hypothalamic amenorrhea. And so those are other people that might be involved as well.
Mm-hmm. All right. So now that we have those follicles that are growing nice and big, typically once you hit a critical point in follicular growth, like they hit a certain size and your brain sends out the message to evict everybody.
Ovulate,
like kick them, grow them up and kick them out. And being the control freaks that we are, we want that to happen when we want it to happen. And so what kind of meds do we use to make sure that we are the ones giving the instructions rather than your brain deciding it's in charge?
So the medicine that Susan talked about earlier, we either give, and it's trade names, either Centertide or Ganirelix, but they're in a group they're antagonists. Basically, they prevent your brain from producing the hormone luteinizing hormone. That's the hormone that normally you would send out or your body would set out when your egg gets to a certain size. And so your body doesn't like to have a whole bunch of big eggs growing. It really wants to get you to ovulate those eggs. And so the way we prevent you from ovulating before we go in to get the eggs out is we start you on an antagonist. And usually we start it roughly about, and give or take a little bit, around day 6 of medicines. And once you start that, and this is a question that I get on phone calls often, once you start it, you don't stop it. You keep going, because if you stop it, then we worry that you would ovulate.
I'm a big fan of this group of medicines because we're going to talk about a few medicines in the future, the ones that ovulate. And if you're on an antagonist protocol, you have options as to which trigger shot you choose to do. Whereas there's another group of medications, Leuprolide, which is a GnRH agonist, and you normally start that either while you were on birth control pills earlier on or right at the beginning. There's different kind of protocols depending on whether we're wanting a flare effect or, wanting it to do a little bit extra. But if you're on that Leuprolide to help prevent you from ovulating, we don't have the same choices when we get to our trigger shots. So because I love Lupron triggers, I don't use Leuprolide. I tend to do antagonist protocols. And so that's just kind of my kind of slant on things.
Do you guys ever use progesterone to prevent ovulation?
I've never used that before. Have you ever used that before?
So I haven't used it. I know we actually started using it during a shortage of medicines that happened recently in some individuals, but
And it worked?
apparently it works pretty well. You can use Provera and
Wow.
it works as well. Do you do that a lot, Carrie, or do you just occasionally do it?
I don't do it a lot. I've got a specific subset of patients that I use it in when I'm trying to really cut down costs on meds. And when I don't have as much expectation of what I'm going to get. Like I'm not real crazy about using it in someone who's got 20 eggs that are going to come out, because inevitably I'm going to have to add cetrotite to it. But for someone who's only going to get a couple, it's avoiding an injection. It's a lot cheaper. You have to give it from the very beginning. And we usually have at least some cetrotide on hand, because there's been times when it just starts to creep up where you just need that one shot to knock it down, and then you can keep going, and the med expense is less. So it's not my default. I don't have as much control over it. And you for sure can't do a fresh transfer with that type of protocol, but we don't really do those very often anyway in our clinic. So I'm not so concerned.
You check luteinizing hormone then?
Yes, that is a default. We check it all the time.
And that's what you check, and that's when you give the centrotide if you need to knock the luteinizing hormone down, right?
You got it. And you need to know that when you do that, you're oftentimes going to see a drop in the estrogen. So don't freak out about it.
You or the patient, right?
You're the patient. Sometimes you have to treat the staff and the doc more than the patient. Okay, so you've gotten your follicles nice and big, and you want to send them the eviction notice. What do you use?
That's what Susan was talking about before. So up until just really probably 4 or 5 years ago in our practice, we would do day 21 Lupron. So patient would get Lupron throughout. They'd start their period, get Lupron all throughout the stimulation. Then we would trigger with Ovidrel, which works great. However, it for patients who have really high estrogen levels, or I've seen even as low as around 2,500, every now and then you have patients who get severely hyperstimulated if you trigger with Ovidrel. And so by that, I mean, we would have patients that would have to come in. They would have extra fluid. We would have to remove fluid from their abdomen. They'd be hospitalized for vomiting. Just all kinds of bad things happen with hyperstimulation syndrome, severe hyperstimulation syndrome. And so probably 4 or 5 years ago, we started doing Lupron triggers like Susan talked about. And Lupron's great because for the great majority of people, it works really, really well. And it has the huge bonus of really preventing, I mean, knock on wood, I know there's a few people that can get severely hyperstimulated, but rarely now does that ever happen. It's almost like for younger physicians who are coming out in this field, it's almost like the same as pediatricians and chickenpox. You just don't see it anymore. There's a vaccine for chickenpox, so young pediatricians don't see kids that have it. Young REI doctors don't see ovarian hyperstimulation syndrome anymore, because most everybody now, I think, does Lupron triggers for that reason.
Absolutely.
In our practice, we have kind of a mixed bag. There's some of us who love Lupron triggers. There's some people who really dislike Lupron triggers. I can say neither of us really understand each other, but we respect each other. but it's it makes a difference. I mean, for me, it gives me, I have patients that are over a very large geographic range. And in that case, first of all, I can count on one hand the number of Lupron triggers that did not work, that there was no writing on the wall. Okay.
Yeah.
And very few have slipped through that I was like, oh, because most people, Lupron triggers are going to work. There's a handful of people. You have to be smart about it and that type of thing. But you're
right. Occasionally, I had a person this year who the writing was not on the wall. She wasn't hypothalamic,
but that's a sign of their underlying fertility. It's part of the IVF is not only therapeutic and that we're helping you get pregnant, it is also diagnostic. Okay. If you don't respond appropriately to these medications, there is diagnosis that's going on in our brain that is forming what are we going to do next. And so and I would
argue in the long run it's disappointing if somebody doesn't respond to a trigger. It's a big deal. We feel terrible about it. But on the flip side, on the other hand, for people that have to get hospitalized with hyperstimulation syndrome, that's a big deal too. And more and more people,
life-threatening big deal.
That's a life-threatening big deal. That's right. Yeah.
We
So-
generally all like to stay out of the ICU. Like I
Yes, we
literally
do.
make myself ill when I have a patient in the ICU because I worry about them so much
Yes.
that I could have never been an ICU doc. I always say I am a professional worrier because I do sit there and I'm like, oh, what's going on with this person?
Me too.
That's part of who we are. I mean, it's what makes us good at what we do. But keeping our patients safe is always number one. Pregnancy is always number two.
That's right. Yeah, absolutely.
Yep. All right. So those are the primary meds we use during an IVF cycle. We're going to hold off on the transfer meds because that is a whole debate that is an entity of unto itself.
That's another episode.
That
Yes,
is a
that's another
whole other
episode.
episode. Yeah, so I hope that this is helpful. And I hope that all of you are having a wonderful day and a wonderful week, and that you come back and play with us next week. So to our audience, thank you for listening. Make sure you come back next week for more. We've got a conference coming up October 28th in New Braunfels, which is between Austin and San Antonio. So make sure you keep an ear out for that, your earballs open. And come visit us and come play with us. Be sure to subscribe. We're on Apple Podcasts and YouTube channel and all those things, Instagram, Facebook. Like us, follow us. Yeah, we love to hear what you're saying and how you react to the episodes, and just to say hello.
You can also visit us on fertility.uncensored.com to submit specific questions. All the questions, just like the ones today, will be answered on the podcast for our Ask the Doc segment. We'd love to hear episode ideas. So keep in touch with us and let us know what you want to hear.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon.
Talk to you soon.
Bye.
Bye.